Good morning. Welcome to our first Nursing Facebook Live. My name is Karen Clements and I'm the Chief Nursing Officer at Dartmouth-hitchcock. I'm here with my colleagues Jen Hannix and Tom Carlson, and we're here to talk about workplace violence. We're a 400-bed Level 1 Trauma Center, academic medical center located in Lebanon, New Hampshire. Our topic today is workplace violence in healthcare. Jen, Tom, could you introduce yourselves and tell us a little bit about your roles?
Yeah, my name is Tom Carlson. I'm the Director of Safety and Security here at the hospital. We have a team of about 35 to 40 security officers. We provide security services to the hospital 24/7 each day of the week.
And I'm Jen Hannix. I'm a nurse manager of a medical surgical floor. We take care of primarily post-surgical patients of the orthopedic and trauma population. And I oversee all clinical staff on the floor, which includes about 90 different LNAs, nurses, and support staff.
Thank you. And again, I'm Karen Clements. My job here is to make sure that I assist in providing a workplace that's safe from harm and a place to give and receive care. So we're going to jump right in to our topic. And so Tom, can you tell us what workplace violence means?
Yeah, workplace violence is OSHA, Occupational Safety and Health, defines workplace violence as any violent act, and that can include physical or verbal violence against any employee in the workplace. Examples of that are harassment, abusive behavior, intimidations, threats. Any type of activity like that is considered violence in the workplace.
And we're finding this extremely impacting our work in the healthcare environment. Just to share some statistics, 1 in 4 nurses have experienced violence on the job. Nurses are at greater risk of workplace violence than prison guards. And 13% of missed days of work are due to nurse abuse. Jen, can you give an example of what we might see here at Dartmouth-hitchcock of workplace violence?
Absolutely. There are sometimes unintentional, as in patients that don't have the decision-making capacity to either verbally or physically act out, but then more importantly, we actually have intentional acts of either threats, manipulation, degradation of staff, calling them names, staff splitting, and sometimes even throwing things or attempting to hit. Those are realities that our clinical staff face sometimes on a daily basis.
Yes.
Yeah.
And Tom, have you seen more aggressive types of violence in some of our workplace areas, like the emergency department?
Yeah, we have. There's certainly been an uptick in violent behavior, particularly in the emergency department. We have a behavioral hallway where we have patients that have mental health issues. There's certainly the opioid crisis has played a hand in that. And you have patients that are coming in sometimes with a combination of both mental health issues and opioid issues that can really act out and be quite violent.
Tell me a little bit more about the behavioral health hallway in the ED and how we've built that to try to provide a safe environment.
Yeah, so we've recognized that that's a very dangerous environment. We have 2 full-time officers staffed in the behavioral hallway 24/7. One is at the emergency department desk that's always observing the waiting room and looking at cameras and making sure that they can be proactive. And then we have an officer stationed right in the behavioral hallway, working with the nurses to make sure that they can keep a close eye on all the patients and be proactive when any type of disruptive behavior begins.
It's important to show that we are tracking these incidences very closely, and as you can see, the significant increase in our workplace violence. We are encouraging every staff member, not just nurses, to report this, whether it's verbal or physical, and this is actually on our Dartmouth-hitchcock strategic plan to decrease these numbers by 25%, and in my world, 60 to 100% decrease. Nurses actually experience biting, spitting. We've had some injuries due to hitting, chokeholds. Those are just some examples of the physical abuse that the nurses receive here at Dartmouth. Tom, who's acting out? Who do you see is acting out in a aggressive way here on campus?
Yeah, primarily it's our patients, and then it's also family members of our patients as well. So those 2 populations provide, act out most of the time. That's when we get a call to handle a disruptive situation, typically it's the patient, but oftentimes it's the family members as well that are upset with the type of care that maybe the patient is receiving.
We deal with that a lot on the floor, that family, we want to be included in care, and they're a very important part of kind of the patient's wellness team, but they're often can be part of the threat or the worry when it comes to potentially violent situations or violent situations. We try to preemptively plan for this as much as possible, and it's a fine line. It's a very gray area where you want to have family, friends, visitors involved in care as much as possible, as much as the patient wants, but we also have to protect staff and protect the patient and make sure that we maintain that healing environment that we're trying to here.
So Jen, we're just going to go down that road. Tell us, tell the audience what we've been doing here at Dartmouth to mitigate some of those things.
So what we often do when we have a challenge where we think that there may be an actual threat, be it physical, verbal, or the possibility for this to happen, we definitely involve security right away. It could be as immediate as pushing a duress button that we have on our badges, to calling security. We try to immediately put in what we call behavioral care plans, where we develop strategies that are patient-centered and safety-centered around how we care for these types of patients. And it can include having, 2 team members go into the room at a time, having security present for certain things, be it walking around the unit or interacting with visitors. We involve our risk management colleagues, because like I said, it's this very fine line, this gray area where we want to continue to be as healing and provide the best care possible, but also keep the staff safe, both physically and psychologically safe. So we try to implement this as soon as we can, and the hard part is recognizing this before an incident happens. So
And we're also trying to keep the patients safe as well. They'll act out where our job is to help keep them safe as well, but certainly we want the staff to be safe, and we want our security team to be safe as well.
Correct. We do know that this is a significant impact on nurse burnout and just employee burnout whatsoever, and we're losing nurses within the first 5 years of their career, and this is one of the major factors. I'll just expand on Jen's. We initiated in February a daily we have a daily safety brief every morning at 9:30, and if any unit, whether it's ambulatory or perioperative space or inpatient unit, they identify even a risk of disruptive behavior, we hold a disruptive behavior huddle just after a safety huddle where, like Jen said, risk management there, house supervisor, security, myself, and anybody else who needs to be involved in that care plan. And that way we're all on the same page for whenever, if ever, hopefully not, a patient acts out or a visitor has a disruptive behavior on the units. Security uses a whiteboard in their office, and they're all informed of what are the hot spots in the hospital, so response is that much sooner. So do you want to talk about Tom Talks?
Yes, so
right. What are Tom Talks?
Tom Talks are when Tom comes up and really kind of helps set boundaries. And this is amazing because it allows nursing to maintain kind of that therapeutic relationship. We really, really work hard we don't want the nurse to be the person that has to kind of set the boundaries. We want the nurse to be the person that provides the care. So Tom and sometimes his colleagues come up and really are the ones that set expectations and help us outline the behaviors and the plan that we have come up with, and really kind of put a no-nonsense framework around what we expect for behaviors. And it's actually really effective. It allows the nurse to maintain, like I said, that kind of healing perspective and continue providing care. And then it also shows that we have a united front as an institution, that it's not just nursing or providers, that it's the entire institution that is coming together to really focus on safety and well-being of patients, family, and staff. So these talks are really effective, and you can talk more about kind of what you do.
Right, and they're a result of things that we've brought up in the safety huddle, and Karen had dubbed it as a Tom Talk because they were happening more frequently. And,
By Tom.
By Tom. So it's a lot of collaboration. So Jen might let me know about an individual that needs a Tom Talk. I will go up there, and the first thing I do is I introduce myself. I let them know my role in the hospital, and then I say, what's going on? What's causing this behavior? And then I actually go into a listening mode, and they pour their heart out to me for maybe 5 or 10 minutes. And I let them know I can appreciate those concerns. I'll try to help you as best I can, but we also have expected standards of behavior in the hospital that you need to adhere to. And we can't have yelling and shouting and swearing. And so we come to a common agreement that I'm going to try to help you out with some of your things that are bothering you, but you have to be polite and respectful to the staff at all times. And it usually ends on a positive note. I'll shake their hand, I'll give them a fist bump, but we have a mutual understanding that from here on out, we're going to have polite and respectful behavior.
And these talks are often very effective because, the thing I always think of is when you go into McDonald's, you don't expect to get shouted at or somebody to swear at you or throw a soda at you, and those things do happen here and can happen here, and that's not okay. And these talks and our collaborative work together really kind of shed light that this is a public space, and most importantly, this is a space where we need to be positive and healing, and that just like when you're out somewhere in the general public, the same kind of behaviors are expected.
So that, just to add on to Tom's, you do set expectations and consequences as well, right?
Yes. So we have zero tolerance for disruptive behavior. So the consequences may differ, but every time somebody exhibits disruptive behavior, we're going to act upon that. And so it may just be simply swearing at a nurse, but we will let them know that that's unacceptable and we need polite and respectful behavior.
And so just to put a little teeth in that, what are some of the consequences if you are, you're intentionally disrupting the workplace?
So we have several different types of consequences, and some of these are outlined in a behavioral care plan that we might put in writing for the patient. It might be that we outline that there can be no swearing, no yelling. There can be times where they not allowed visitors any longer. Visitors may be searched. There's times where we've banned patients and visitors for 24 hours, 72 hours. Some family members have been...
cool them off maybe a little bit?
To cool them off, get a cooling off period for 24 hours. Some family members, if they're very violent and act out in a violent way, they may be banned permanently. So it can range from just simply a verbal warning to actually being banned from our facility because they've exhibited threatening behavior.
How often do we get Lebanon Police, our partners in the community, involved?
Yeah, we have a very close relationship with Lebanon Police. They do an outstanding job. We try to handle situations as best we can, but oftentimes it might get to a point where we just can't handle any longer. We might ask somebody to leave the facility. If they're choosing not to leave, we don't want to have to physically intervene. We just call Lebanon Police. They respond very quickly, and they will escort them off the property. So anything that goes beyond our responsibilities, our capabilities, we get Lebanon Police involved.
Or same if there's like property destruction or something like that.
Yep.
If somebody damages equipment in the room intentionally, those are whole different spectrums of things that.
Yep. And sometimes individuals may want to press charges, and so we bring Lebanon Police in to let them know that we will be pressing charges. There will be consequences.
And that's a very big culture change here at Dartmouth-hitchcock. So helping staff, who are here to take care of patients, think differently about aggressive behavior. And it's okay to press charges against someone who's intentionally hurt you. If you were in McDonald's and you got punched, what would you do? Would you just go home? No, you would call the police and get involved. We have destruction of property, and now we are asking patients or visitors who are intentionally destroying property to be held accountable to that.
I think you bring up an interesting point because, when you mention you just go home, that is something that is within the nursing culture. There's not a whole lot of other professions where you go into work and you say, I might get hit today. And there are times, sadly, unfortunately, that nurses may feel, if I get this assignment, I may get hit today, I may get spit today, somebody may throw something at me. And that is mentally wearing, and we see effects of that on staff, which is why we try to get ahead of this. I think not just the potential physical injuries are a focus, but the mental effects, the well-being, talking about how people feel and preventing burnout and PTSD, which does happen from these types of events with nursing staff, is really, really important to shed light on and make sure we have support. Like we have had EAP involved, chaplaincy, even just debriefs as a group, bringing in leadership to talk about things, and really kind of focus on that emotional well-being as well of our staff.
And you're leading the way in trying to get this to be in our daily life about debriefing these type of events. We're very good at doing an immediate debrief when a patient has a medical emergency and it's very traumatic to the nurse, but we're not very good at debriefing a physical or verbal abuse, and so you're leading that project.
Yes, so we actually on our unit have what we call a disruptive patient work group, because unfortunately we do see this a fair amount with the population on our unit, and this was something that staff were really vocal about, and I really appreciated the importance of this, and we through this work group are starting the work of creating a kind of disruptive incident debrief, where in the moment, just like you said, when we have a significant medical event, we talk about not just the factual stuff, but how it felt to deal with that event. But we don't do that quite well when there is a patient that attempted to hit you or made a threat or said, when I get discharged, I'm going to find you and harm you. Those are real significant things we need to talk about and we need to bring forward, make sure that we have systems in place to support staff and systems in place to continue the work that we're doing to prevent and educate both the staff and the patients and families about kind of what our expectations are.
And it's important for the staff to recognize what is disruptive behavior, what is workplace violence, so that they can report that and we can collect those statistics and then we can act upon that and put those corrective action processes in place.
We're talking about inpatient units with Jen here, but Tom, talk about different areas of our facility where we've seen disruptive behavior.
Yeah, so we, most of the disruptive behavior, I would say 80% of our disruptive behavior happens both in our patient towers, where we have a large populations of inpatients, and then also in our emergency department. So knowing those statistics is important, so we deploy a lot of our officers. We spend a lot of time in the patient towers doing rounds, daily rounds, and we also spend a lot of time in the emergency department, so we can be proactive. The goal is to get ahead of this disruptive behavior so that we can quickly de-escalate it, and by deploying our officers in the right locations, we're able to do that.
So you're seeing that in all of our areas, ambulatory, emergency department, our clinics, sometimes in our peri-op recovery space, so it's not just an inpatient problem.
It's across the hospital. We have a pain management clinic that has a lot of patients that are on opioids, and sometimes they're trying to be weaned off of opioids, and they can act out as well. Each afternoon, we meet with the management team of the pain management clinic. We review the rosters of the next day's patients, find out, has there been a trend? Have they acted out in the past? If they have acted out in the past, they've demonstrated disruptive behavior. That's good for us to know, because when they go there for the appointment, we can have an officer close by. So if they do act out, again, we can get ahead of that disruptive behavior and quickly de-escalate the situation.
I have a question, but just to finish this note, we're actually talk about the community group practices as well, which is part of our Dartmouth-hitchcock family.
Yeah, so our community group practice and our affiliates, we're implementing the same processes and same procedures that we have here. We want to roll out workplace violence initiatives, training for the community group practice. Same thing that we're doing here to have consistency across the board. They have the same issues that we have, maybe not to the same volume, but the same types of issues can occur at those locations as well.
I'll just take this question and then we'll go into some of our signage and education practices that we're doing. The question is, do EMT providers face similar violence and abuse? Does the hospital work with EMS providers on this topic? So we haven't worked directly with them, but I do know at a state level, the police departments and the EMTs, and Jen is an EMT, so she can answer this, undergo specific training on how to deal with violence in the pre-hospital field, and I know the police do as well.
Yeah, I've actually been an EMT for 17 years now, I think, if I'm doing the math correct.
Yeah.
I don't do it full time any longer, but when I did, and this is something that I know probably every single EMT has dealt with in the back of an ambulance, and it's scary because you're in a 10 by 8 box and you can't go anywhere. There's actually a lot of training. It does vary a little bit, but that pre-hospital providers receive about how to position themselves, how to avoid these sorts of incidents, but it still does happen. I do know we have the EMS coordinator that works kind of in liaison. I think this is a great question. There's definitely opportunity in this space when I know that security assists ambulances as soon as they arrive, Lebanon PD, the same thing. So we do work with them in that sense when they get here, but this is a very interesting topic, and I think that EMS agencies and fire departments have an opportunity to come together and also bring this forward because it is definitely something that I think isn't really in the spotlight. So,
agree. So you may see this sign behind us. So we've been working on some signage here at the medical center and the community group practices on just, doing a visual display of our expectations of patients, visitors, staff, etc. And so you'll see these signs at our main entrance and throughout the facility here on the Lebanon campus, but also on our community group practice campuses. They've been very well received. In fact, across the country, there's very few hospitals that are displaying this, but it's a growing interest, and we've shared our sign with multiple hospitals across the country. Again, we want to emphasize that this is a healing environment, and we're here to care for you and take care of you and your loved ones and your family. And so to read the sign, as you can see, Dartmouth-hitchcock is a healing environment. Please treat others with kindness and respect. And down below, it just kind of outlines certain specifics. Dartmouth-hitchcock has a zero tolerance policy for any type of aggression, including abusive language or verbal harassment, sexual harassment, threats of harm, physical assault. And again, we set the expectation and the consequence that aggression may result in removal from the facility and or prosecution. And then security's number is on there to call. Again, we start with the kindness of we want to be here for you and care for you, but again, we expect you to act, like a nice human being.
that's very true.
Just be out there. Tom, you want to talk about some of the training that's going to be coming on board to assist all of our staff on how to deal with different types of behavior?
Right. So with all this, the workplace violence and disruptive behavior, how do we handle that? How do we train our staff to deal with this? So some of the training platforms will have e-learning modules where, depending on the units, the level of threat they're exposed to, there'll be training programs that are designed specifically for those units. For example, if you work in one of our psych units or maybe the emergency department or certainly the security department, you're going to get the full plethora of training, both nonviolent crisis intervention training and then what we call MOAB training. It's management of aggressive behavior, how staff can position themselves while they're caring for the patient, how they can protect themselves, maybe how you escort a patient from point A to point B without the patient getting hurt, without the staff member getting hurt. So that's a platform that will be launching in the last quarter of this calendar year, and it'll be just a lot of different training for the different groups, the units across the hospital and also in our community group practices as well.
I'm really excited about this, and I know this is something that we've done some surveys and conversations with staff that additional training and support is actually something they want. And I have to say, in the last year, your department and my department partnered very close to work with some difficult instances where we needed more education. And it's funny because a lot of clinical staff, nurses, LNAs, we're taught to look at patients differently. We naturally get in people's bubbles. We get very close to people, and that's because it's part of our job. And as security, you have a completely different lens. You look at a situation and look at potential and look at body position. And we had instances where staff would be leaning over a potentially aggressive patient and that we had plans in place for, but still they wouldn't realize they were leaning too close, and a security guard actually was partnering with us and would say, your elbow, watch the elbow, or tell us how to move. And we never even realized it without somebody with that different lens. So it just shows how important that training and that partnering is to help us maintain a safe environment.
Yeah, and as I walk around the hospital and talk to a lot of different staff members, they're all asking for more and more training. So I'm glad that we're going to be able to launch those training programs and be able to provide the necessary training to keep them safe.
Yeah, I've actually been trained in both CPI and MOAB, and it's to the day, we've come to the day now where a nurse actually not has to learn how to be a nurse, but also how to get out
That's
of
so
things
true.
like a chokehold or a hair pull and such like that. And those are tools that we don't learn, and we have to learn and practice. We actually practice on each other during MOAB on how do I get out of a chokehold, and how sad
They
is
don't
that?
teach you that in
They don't
nursing
teach you that in
school.
nursing school. And how to fall instead of go forward. And so it is what it is, and we have to provide that training. Another software that we're looking for is how to interact verbally with a patient in the time on how to not escalate the patient. There are certain cues and words that we don't learn very well unless you're in the situation. Every patient is unique and individual, and we need to teach all of our staff, not just nurses, on how do I respond to that patient? How do I make sure I don't be the aggressor and cause
you
them
wanna
to escalate. You want to
de-escalate.
de-escalate. So
Yeah.
we're going to have those tools as well. So I'm very excited about that. It's just part of our toolbox on how to maintain a healthy work environment. So we talked about supporting a new nurse on workplace violence, the work on doing the de-escalation. And can you tell us why we're seeing this increase throughout our healthcare environment of this violence?
That's a great question. Well, certainly, I think we're seeing a greater volume of patients come through the hospital. So just the greater volume, the greater throughput is going to increase the disruptive behavior. And then, as we mentioned before, there's a mental health crisis in this country, and it's not just in New Hampshire, but it's across the country, and we're seeing that. I don't think we have adequate facilities to
support
support these individuals. So a lot of them will end up here, where you certainly have a drug crisis, an opioid crisis, and that we're trying to get ahead of as a country. But we're seeing that here, certainly in the hospital, and so you're getting those situations and combinations of both those together. It can create a very volatile and explosive situation.
We see that a lot as a post-surgical unit. Pain and management of pain, especially complicated with mental health challenges and going through, significant procedures or life-changing events. All of these things are a pinnacle to have kind of uncontrolled emotions come out. And this is something I think that, as you mentioned, all of these things are prevalent in our society, and as a level 1 trauma center, these are the patients that are coming to us because we are the largest hospital in the state. So we're kind of seeing the influx of some of the most challenging and acute patients, which bring more of these issues to light.
Yeah.
I would tag on to that the acuity of our patients has increased over the past 2 years. So with acuity and stress, that increases the stress on patients and families and loved ones. People travel from a long way to get here.
They do.
And so
That's a good
just
point.
trying to mitigate their stress as well as they get here. We all only take the sickest of the sick patients, and so that over the last 2 years we've seen that increase significantly.
Right. And it is stressful just to come to the hospital. So we try to make sure that even when they arrive at the hospital, they find a place to park. We can escort them into the building and help them find where they need to go.
Another question I think will go, what are the next steps in providing physical safety, such as lockdown for the never events, in addition to training and great reaction to concerns?
Yeah, that's a
that,
good
Tom?
question. Yeah, so we've done a lot in the last 2 years to help increase the safety of the hospital. We've put a lot of additional controlled access card readers in place, increased the number of cameras. We have a lot of controlled access, video surveillance. The units now where Jen's team works, they have the ability to lock down their own units. We have a lockdown button where you just push the button and that unit goes into a full lockdown mode, so they can do that themselves. So we've done a lot of things to enhance safety and security over the last 2 years, and we're by no means finished. We have a lot more things on our plate, but I think we've made some really good progress.
Jen, why do you think we don't lock our units 24/7?
So we have a lot of patients, visitors, and people coming in and out, and it's a fine balance of maintaining that, as the sign says, healing, open environment versus seeming like a very shut, cold, closed area. So I think that's the hardest part. It's something that we do lock our units at night because we recognize that that kind of is a time where visiting it isn't as appropriate on an open stream basis. We still do encourage visitors all the time, but there's more of a controlled process because there's also less people here, and we really want to be open and be healing and be welcoming. So how do we do that and mitigate these risks is a very real talk that we have on an ongoing basis.
Tom, do you want to talk about our visitor management system and how we control our entrances?
Yeah, so during the daytime, as Jen said, we're a wide open facility.
And how many doors do we have?
We have probably over 1,000 different doors where people can come in and out of. At nighttime, at 8 o'clock at night, though, we do begin shutting down the hospital. So after 8 o'clock, there are only two entrances that visitors can come into, and that's in our north entrance and our emergency department. At 11 o'clock at night, that goes down to one entrance. All patients that come into the hospital, visitors come into the hospital, have to come in through the emergency department. We have a software system called Passage Point. Everybody gets checked in. We get their names. We find out where they're going. They're issued a badge that they have to display in the hospital, and then they go into the hospital and we guide them to the area where they need to go.
And those badges, do they like expire?
Those badges for 24 hours, so after 24 hours they expire.
They like
And,
do
They like change
they
color or something?
They dissolve,
like
and so
fade
they fade out,
yeah.
so they can, and
They self-destruct.
they
That's
almost
what
self-destruct,
do.
yeah, kind of like the Mission Impossible.
Wasn't that
Absolutely.
Inspector Gadget with his briefcase?
Yeah.
I'm sorry, I'm dating myself. That's-
People ask me all the time, what does zero tolerance mean? What does that mean? And I think it's just changing our culture to not tolerate any disruptive behavior. And that's a change in healthcare because, as Jen said, we're healthcare providers. We don't expect this kind of treatment when people come here, but we have to raise our bar of expectations to zero tolerance of that. And again, it's an individual event. We treat every event very differently. We debrief them. We try to be proactive. And I believe since we started our disruptive behavior huddles, we've seen a decrease in the acute reaction of
Yeah,
patients
no-
with our
no
Tom
question.
Talks as well.
I do feel like we have a much more well-oiled system to deal with this in a faster way, if that makes sense. We can, within the same day, have a plan and have resources in place. And to just tag on with what you said, I think it's important to raise awareness, not just for patients and families about zero tolerance, but to staff. One of the things I struggle with in my role is having staff understand that, no, this is not okay, and yes, this needs to be reported, even if it's something that is verbal, which they're like, they didn't mean to say it, or there's a lot of excuses, but we can't track and understand the full scope of these instances if we don't truly recognize first that this is not okay and that our culture is zero tolerance and that we need to report and talk about it, because when we do that, then we can realize the scope of the challenge and deploy the right resources. And that's exactly what we did in the past year when we had, that a specific incident on our unit. I feel like that bringing awareness and staff education and making that our culture and expectation in our unit really helped.
Right.
So,
what are the barriers you think to staff, reporting any of these incidences?
Yeah, that's a good question, and I think Jen brought it up too. Sometimes nurses have been working for 30 years, and I said, I've seen this before, I've dealt with this before, I'm tough, I've seen a lot worse than this, so I'm going to handle that.
or sometimes patients apologize. They're like, "Oh, I'm sorry, I didn't mean to do it,"
that,
and then they'll
yeah.
do it again
Yeah.
the next shift. Or people have different levels of what's acceptable, that based on their lives, their experience, their understanding. So
And taking the time to report something. Well,
Yeah.
I'm busy, I don't have time to sit down and document all this and report it.
Yes.
So we want to try to simplify the system so that they go into our OWL system, report it, and it can be tracked and logged, and then we can take corrective action.
And the
Right.
number one thing I think staff and everybody needs to realize and understand that the report is meaningful, that it is something that leadership takes seriously, that we follow up on,
We
that
act
we
upon
review.
that, yes.
And so it's having faith in the system
Right.
and knowing how important the platform is. So I think that is really kind of pulling that whole thing together. You take the time to do it and it will be meaningful.
Yep.
Before we get to another question, I just want to talk about what we're doing at a state level. I'm working with our legal team and the New Hampshire Hospital Association to change the the legal offense to when you assault a healthcare worker. Maine and Vermont have done that. It's on the Massachusetts ballot. But right now, if you assault a healthcare worker, there's really not a lot of teeth to that offense.
No.
And so I'm going to be pushing that with my legal team to, if you do, intentionally hurt a healthcare worker, then you're going to have some heavier consequence. The question is, what can non-clinical staff or other visitors do to support these efforts? Well, like in airports or in any, we're in a society now where shootings and, terrorism, domestic terrorism is happening all the time, and so be aware.
See
something, say something.
Yeah.
Exactly.
Yeah.
So we expect our visitors, our own teams, and
Call
non-clinical people who work here. They're our employees. We want them to be safe as well. But again, be vigilant. Be aware. Don't hesitate to reach out to security if you even think that there's a potential, because then we can get in front of it.
Yeah, we're there to help and support, and this is a team effort with everybody. It's our staff, but it's also our visitors as well.
Security has increased their numbers of staff here. We have daily rounds, hourly rounds. I think so. We see security frequently throughout the building. They're appropriately dressed, so people know that we have a security presence here. We also have them now at the CGPs, and so they're always accessible. So great question, and it is a team effort here at Dartmouth. Can people feel safe coming to our facility?
I think absolutely. I think we're, as you mentioned, we're a very welcoming and warm environment, and we're here to help and heal patients that are coming to the door. And we have a lot of contact security does with our patients and visitors. We meet them from the time they come onto the property. We have a courtesy van where we will pick them up, bring them to the front door of the hospital. We help them get out of their vehicles. We help them into the hospital, help them to find their appointments. So I think all of our team and the rest of the hospital very helpful and supportive in trying to make the experience when you're in the hospital. Sometimes it's very stressful to de-stress that and help them as much as we can so that they're not stressed about a parking space or they can't find their appointment, they're going to be late. So I think it's a very welcoming and warm environment in the hospital.
I think that, just because we talk about workplace violence doesn't mean we're not safe. I think this is something we talk about because we want to be safer, because really it shouldn't happen at all. It is something that just shows that we are in the mindset of being open and healing and really transparent with everybody about what our expectations are as healthcare providers and as an institution. And also, we've said so much that we want to maintain that openness. That's how we have these certain relationships with security and the plans we put into place, because really they're all centered about the patient and about the care that is provided. But ultimately, we need to make sure that the staff and the other patients and other visitors within this institution are safe. So essentially, we don't want like one bad apple to spoil the whole bunch. We are a safe institution, and talking about it is only going to make it better.
And we have a lot of security, but I refer to us as customer service officers. Yeah. That's what we are. We provide customer service most of the day. It's a very safe environment, and that's what we do. We help people find their cars. We help people find their appointments, where they can go to eat a good sandwich or whatever it might be. So we're here to help as best we can.
Yep.
Well, thank you. We could go on for probably another hour, but we're going to wrap up. So the whole point of this is we really just wanted to talk about it and get the conversation going. But we want our patients and our staff and our visitors to know, that we are a healing environment. We want to take care of you, but we also want to set the expectation of behavior when you come to one of our campuses, and that we expect their code of conduct when you come. So again, thank you all for listening to us this morning, and we're going to continue this great work here at Dartmouth-hitchcock. Have a great day.
Thank you.
Thanks.